In this video, we show the use of oral mucous membrane graft for ocular surface keratinization in Stevens-Johnson syndrome. Our case was an 18-year-old male who presented to us in 2017 and was diagnosed to have chronic SJS sequelae. He underwent left eye both lids MMG and right eye upper lid MMG. He was lost to follow-up and he presented to us 5 years later with a stable ocular surface in left eye and a keratinized lower lid margin, inferior bulbar surface and inferior cornea. A right eye lower lid and bulbar surface MMG was planned. During surgery, stay sutures were placed to both lids using 4-0 silk. Using 15 size blade, incision was given along the grey line and 5 mm posterior to the lid margin. Using limbs forceps and Vanna scissors, a dissection is done carefully along the lid margin, removing only the skin and the keratinized part of the posterior lid margin. Care is taken to not excise excess tarsal tissue. The keratinized conjunctiva over the tarsal surface is also excised. Now the bulbar surface keratinized conjunctiva is excised, taking care to not remove excess of Tenon's tissue. The dissection is started at the limbus and then proceeded towards the fornix. The corneal keratin is removed using a 15 size blade. The surface is smoothened and finally a keratin-free surface is achieved. The bare area is measured using a sterile scale and the same area is harvested from the lower lid labial mucosa. The area to be harvested is marked with the marker pen. And incision is made using a 15 size blade. Submucosal dissection is done along the lamina propria plane, making sure that excess fat tissue, salivary gland lobules and muscle tissue are not included in the graft that is harvested. The lip wound is sutured with 7-0 vicryl in a continuous interlocking fashion. The graft is placed over glabella and excess fat tissue is trimmed using curved part of Westcott scissors. The graft is divided into two equal halves, one half for the lower lid margin and the other half for the bulbar surface. The graft is sutured to the lower lid margin using 7-0 vicryl in a continuous interlocking fashion. The graft is thoroughly hydrated during suturing to avoid shrinkage of the graft. Posterior margin of the graft is attached using fibrin glue. Ironing of the graft is done using iris depositor. The second half of the graft is placed on the bare area of the bulbar surface and fibrin glue is used to adhere the graft to the bulbar surface. The caveat here is to keep a minimum gap of 1 mm from the limbus to avoid migration of the graft onto the cornea later on. To keep the graft in place, in addition to fibrin glue, stay sutures are placed using 7/0 vicryl at all 4 ends and 2 sutures in the middle of the graft. A total of 6 sutures are placed to keep the graft in place. An amniotic membrane overlay is performed for the corneal epithelial defect. 2 weeks later, we can notice that the keratin has not recurred and the graft is well taken up over the bulbar surface and lower lid margin. At 1 month post-operative visit, the vision had improved from hand movements in the preoperative period to 20 to 50 1 month after surgery. There is also regression of corneal vascularization. The graft is well vascularized and well integrated on the bulbar surface and lid margin at 1 month post-op. Thank you for your patient listening.